A hip joint is a great example of a ball and socket joint. The shoulder is another example of a ball and socket joint. And these joints generally permit flexion, extension, adduction, abduction, and medial and lateral rotation. So sometimes there are dislocations of the joint. And in a dislocation, there's a separation of two bones where they meet at the joint. So here we see an example of a dislocation of the hip joint. And the head of the femur has been dislocated from the acetabulum of the pelvis. Here's an example of what a dislocation looks like following hip replacement surgery. So you can see where there's prosthetics in use here. There's a prosthetic of the acetabulum because you can see the screws where the surgeon has put a new acetabulum in. And then we can see that the femur, there has been a prosthesis added to the femur that has a new femoral head and neck that would normally be connected into that acetabulum, but in this case it has been dislocated. Okay? Subluxation is a partial dislocation of the joint, and so this usually maybe heals sooner and may not require surgical intervention, but it is what is considered a partial dislocation. So how do we treat a dislocation? Closed reduction is one way, and we reduce the dislocated joint under sedation, and this is non-surgical. So we would give the patient some medication like some Versed and maybe some other medications to control pain, and then the physician would actually manually reduce the joint back into place. Again, this is non-surgical. Another option is an open reduction, in which case the dislocation must be reduced under anesthesia, and this is a surgical procedure requiring an open incision. So let's take a little bit of time to talk about diagnostic testing. So arthroscopy, we talked about a little earlier, is an excellent way for a surgeon to visualize the joint cavity using an irrigation cannula to add fluid or air into the joint space so that it can be visualized. And again, this can be for diagnostics or for repairing of some torn tissue. The shoulder, the elbow, the wrist, the hip, and the ankle. These are some of the places where arthroscopy can be used to diagnose and treat musculoskeletal disorders. Fluoroscopy is an X-ray machine that's on a C-arm, and it's kind of like an X-ray movie. So it's used to diagnose by displaying the movement of a body part in detail. And we have a picture of one coming up here. It may also be used during a surgical procedure to assist the surgeon to realign the bones. And so here we see an example of a fluoroscope. We see the C-arm, which is movable, and we can take moving pictures that you see the physician looking at up there on the computer screen. MRI, magnetic resonance imaging, is another way that we can diagnose injuries of the musculoskeletal system. Radio wave and magnetic field are used to view soft tissue, and MRI contrast material may or may not be used. So if you're ever working in an environment where you are someone who's responsible for ordering MRIs, it's always very important to ask the physician if he or she would like that with or without contrast. So these radio wave and magnetic field images, our MRI images, are used to view the soft tissues of our ligaments and cartilage, tears, osteomyelitis, which is bone infection, which we will talk about in a little bit, and disc disease as well. So here we have an MRI of the lumbar spine, and we can see that there is a herniated disc at L5 there protruding through. And this can be very painful because it can compress on the nerves. Okay, so this is what an MRI of the spine looks like. Contraindications to MRI include pacemakers, aneurysm clips, depending on their type, any kind of metal, hearing aids, shrapnel, and the patient is to have no metal on their clothing. Usually they would have a hospital gown on when they go into the MRI machine. And this is because this strong magnetic field may actually cause one of those metal pieces to move or cause tissue damage surrounding it in the body. And so we want to always ask our patient if they have any of these before ordering an MRI for them. So here's an example of a closed MRI. We have something called an open MRI, in which you do not go into this very small confined tube. You can be in a kind of a more open space where they can take the same pictures, the same quality of pictures, for those patients who do not tolerate closed spaces. And then, of course, we have our standard X-ray. And X-ray can give us information on the density of the bone, fractures. We can see dislocations on X-ray, like we saw a little bit ago with our dislocated hip. And we can see the joints. We can visualize the joints. But the advantage of MRI is to view some of the soft tissue, whereas in the X-ray, mostly we're just looking at bones. Okay, so now we're going to talk a little bit about fracture of the hip, which is a common occurrence for patients that we take care of in the hospital. And so here we have another picture of our femur bone, and we can see the greater trochanter and the lesser trochanter, but this time I want to focus on the area in between called the intertrochanter area, and this is between the greater and lesser trochanter. This is the most common place that hip fractures occur. Okay, so this intertrochanteric place is where most hip fractures are common. So open reduction internal fixation of the hip is to open the hip with a surgical incision, reduce the dislocated joint or realign the bones, and internally fixate what has been torn apart back together. So in this case, we can see a hip compression screw that is going through the femur, up through the neck of the femur, into the head of the femur, stabilizing that bone so that it can go back into place. The head of the femur can go back into the acetabulum, and after some physical therapy, our hope for this patient is to regain quite a bit of their mobility. So here are 4 types of hip joint repair. In the one labeled internal fixation, what we're seeing are compression screws, actually just the screws, the pins that are used to fixate the head of the femur to the actual bone. So here what we had what we refer to as a transcervical fracture. And these pins are in place to fix that bone back together. In the one that says hip compression screw, here we see this patient has sustained an intertrochanteric fracture. So we've got the hip compression screw in to, again, connect the femur back to the head of the femur so that we can then place the head of the femur back into the acetabulum if it has become dislocated as well. Next, we see an example of hemiarthroplasty. And arthroplasty means that we are using some kind of prosthetic device to reattach and realign. So we have a prosthetic device that is inserted into the femur. In the hemiarthroplasty, only the the top or the head of the femur has a prosthetic device now placed into the patient's acetabulum. And in the one next to it, referred to as the total hip replacement, you can see that not only have we replaced the head of the femur, and it is also we are replacing the acetabulum as well. So the acetabulum of the pelvis has been replaced with a prosthetic device, and the head of the femur, as well as the top portion of the femur, has also been replaced with a prosthetic device. Here we're going to talk a little bit about hip precautions. After a patient has had a hip replacement, there are certain things that we do not want them to do. And one of those things is to cross the legs, all right? So we do not want the legs to be crossed. And one of the ways that we do this is by placing an abductor pillow between their legs to keep the legs separated. The other thing this helps is to keep no internal rotation of the hips, okay? So what we don't want is for our toes to be pointing at each other. So we want them to remain straight. So that's another thing that our adductor pillow may help with. So if we remember, going back to this slide, abduction again is away. So when I'm moving my arms this way, I'm abducting, and if you can see in the picture, the legs are being separated and kept apart by the abductor pillow. No bending or sitting at a 90-degree angle. In certain hip replacements, this is a possible risk for dislocating the hip that was just fixed. So no sitting at 90 degrees. Here we can see an example of that. So we want to make sure that we use chairs that are raised. So we don't want to use low chairs. And we want to use elevated toilet seats or bedside commodes to help keep the patient up so that they don't have to sit at this low 90-degree angle. We want to follow weight-bearing precautions, and we're going to look at some examples. Non-weight-bearing, NWB, is no weight-bearing on the leg at all, okay, that's affected. Toe-touch weight-bearing, TTWB, is only toes touching the floor. So this is usually about 10% of your weight can be put on your surgery leg, okay? Partial weight bearing is when the toes and the front part of the foot can be down, and so about 25 to 50% of weight can be put through the surgery leg. This is partial weight bearing. And then there's weight bearing as tolerated, and what this means is that they can put as much weight on the surgery leg as the pain level allows. Okay. Full weight bearing means that there are no weight bearing prescriptions or restrictions. So this means that the patient is at the point of rehab where they're really not feeling a whole lot of pain, and we're just doing full weight bearing exercises and range of motion to get them as much mobility back as we can.